Sure, I've given you Imitrex and that fails. I can't give you Percocet to help you go to sleep and recover so you can function the next day. That's nice. Okay? We've been treating people with severe pain condition because of migraine, as well as being on benzodiazepines safely this whole time. None of our patients have overdosed and died. There is no call for that. That should be struck from this. Again, benzodiazepines are psychiatric medicines. First and foremost, when you start putting these regulations together, you're attacking us. You're attacking us and our patients. Yes, benzos are used in lots of other patient populations, but first and foremost, they're anti-anxiety medication. I treat substance abuse. That's what I do. We go to this CME, that comes around. We have to take it every couple of years, which is a good thing, and that's what we can do as a medical society is educate physicians on how to treat pain. But I go there's never a psychiatrist speaking. But and there may be addictionologists, whatever their training is, but someone who actually understands people's minds and spends a lot of time with them, understands the fundamental internal stresses, external stresses, and constitutional factors that allow some people to become addicts, others don't. There's never anyone like that up there talking. I'm sitting there listening to these people telling me all this stuff, and think, you guys don't know what you're saying. In any case, as you can tell, I'm very angry. And we both are, because this is going way too far. And I disagree with Dr. Grantham. I disagree with the last speaker. Benzos should not, if you adopt the 3 points, take benzos out of there. I don't want to do PMPs and drug sprees, and I don't want to be doing them on 6-year-old patients on Adderall. I mean, that's absurd. And those are my main points. And I guess let me close by saying, and Dr. Brooks, if we have any time, I want to say something. Another thing I want to realize, all these things go in cycles. I remember the crack cocaine epidemic and the crystal meth epidemic and everything coming in. The opioid epidemic is a phase. It's going to pass. It's not going to last forever. And we've already done the most effective thing we can do, educate through physicians through mandatory CME, so we start turning back some of the stuff we were doing when we were telling everyone that pain is another vital sign, which I thought was absurd when that came out anyway. But nevertheless, we do need to treat people's pain. We shouldn't let them suffer. And so we've done that. Let the law enforcement go after the Chinese fentanyl, because it's not us that are giving those patients fentanyl to die. If you read the news, it's fentanyl that's coming from China and from labs set up in America by Chinese suppliers. And those are the people that need to be caught. Okay, one last thing, in perspective. And you can look on the CDC and find this stuff. In 2015, 33,000 people died of opioid overdoses. In that same period, 88,000 people died from alcohol-related deaths. And in that same time period, 480,000 people died from tobacco-related deaths. If we want to really help our patients, maybe we should be doing nicotine PMPs. And maybe that would do some good. We need to look at it in perspective. Yeah, Donald Trump thinks this is the biggest thing in the emergency right now, and so does a whole lot of the news population, but it's basically an example of a kind of a mass hysteria. I'm not saying there is an opioid problem. I'm not saying we shouldn't be providing lots of treatment, although I disagree with that Suboxone is the answer because it's just giving one opioid for another. No one talks about naltrexone and blocking opioid receptors and getting a shot every month to even took heroin with it. So that's my basic rant for today. I don't have any time. If Dr. Rose could say anything, we have a minute or two left here. 2 minutes. Okay?
I didn't know I was going to speak this right here. I just wanted to say, America's increasing healthcare costs is a national problem. These proposals will needlessly increase the cost of medical care, from wasting paper and printing to prove that our word isn't good enough, to the cost of mandatory drug testing. This will burden our patients financially and greatly inconvenience them. Stellar practitioners frequently do not have access to labs easily. Who's going to pay for all this unnecessary drug testing? If someone who has good sleep hygiene and they're an executive and they can't sleep and they have severe insomnia, a little bit of resveratrol may really help improve their functionality. Should we automatically get a drug test on them and then every 3 months?
It's kind of humiliating for the patients, and especially the psychiatric patients.
And what's
Some of them
really,
are paranoid, and you say, well, I gotta check things on the computer, they're gonna walk out the door.
and what's really important is the Therapeutic Alliance, and we've trained for years, and we've had all this training, and we're not being allowed our medical expertise to make individual decisions. We need to treat the individual patient, and one size, one treatment cannot and should not treat all. Everyone is unique. These proposals discriminate against mental health patients. And, please, I'm sorry, I'm a little nervous. Please let us do what that particular patient needs at that time. Let us be doctors and not police. Again, please let us be the physicians who continue to be educated for, practicing the art of medicine for each and every patient, and not blindly applying inappropriate mandates to patients who entrust their lives to us. One size does not fit all. Our patients deserve best, or better. Thank you. Sorry.
You took 8 minutes and you gave your wife 2. Now, from Forest General Hospital, Dr. Melita Miller.
Doctor.
Melita Miller.
Good afternoon, and I'm Melita Miller, and I'm a registered nurse, and I'm the administrator for Forest General Hospital's Home Care Hospice and Asbury Hospice House. I'm also the president of Louisiana Mississippi Hospice Palliative Care Organization. So today I'm here on behalf of LMHPCO, our 15,000 hospice patients in Mississippi, and our 76 hospice providers, members that are part of our organization. And as hospice providers, we recognize the urgency of this health epidemic, and we want to be part of the solution. Before you adopt restrictive regulations, please allow hospice providers' concerns to be heard as an opportunity for those providing care to the patients of Mississippi, and to provide our input to help develop the most appropriate language to fit the needs of our community. LMHPCO recognizes the importance of the Mississippi physicians, the importance that Mississippi physicians have in curtailing the opioid addiction, and we applaud the Mississippi State Board of Medical Licensure's opioid task force. However, terminally ill patients in Mississippi have a unique dependency on quick access to these same opioid medications in order to manage pain at the end of life, as well as to enhance the quality of their life. Hospice care is a service delivery system that provides care when life expectancy is 6 months or less, and when curative or life-prolonging therapy is no longer indicated. While dying, we all know, is a normal part of life, death is often treated as an illness. As a consequence, many people die in hospitals, some die alone, and unfortunately, a lot die while they're in pain. Hospice focuses primarily on anticipating, preventing, diagnosing, and treating symptoms experienced by patients with a serious or life-threatening illness, and we help patients and their families make medically important decisions. The ultimate goal of hospice care is to improve the quality of life for both the patient, the family, regardless of what their diagnosis is. As the end of life approaches, the role of hospice care intensifies and focuses on aggressive symptom management and psychosocial support. Patients who are nearing the end of life may experience extreme symptoms that include physical, spiritual, and psychosocial suffering. The alleviation of suffering is an essential goal of hospice care. Factors important to seriously ill patients include adequately controlling the pain and other symptoms, avoiding prolongation of the dying process, achieving a sense of self-control, finding meaning of life, and relieving the care burdens of family and loved ones while strengthening and completing those same relationships. As death becomes near, the symptom burden increases while patient and family tolerance of physical and emotional stress decreases. At this time, our primary palliative care interventions should take precedence, and the focus on addiction, misuse, and abuse should decrease. Pain is the most prevalent symptom near the end of life. Unrelieved pain can be a source of great distress for patients and families and exacerbate other symptoms that the patient may have. Therefore, adequate management of pain at the end of life is imperative. Opioid analgesics are the standard of care for treating moderate to severe pain in patients with advanced illness. Dyspnea is a frequent and a distressing symptom, particularly in young patients. Opioids used in conjunction with benzodiazepines are among the most widely prescribed medicines for treating dyspnea. As death approaches, the use of opioids may become more aggressive to manage these symptoms and alleviate suffering. While some attending physicians are unfamiliar with the skills required to adequately manage pain, the attending physicians regularly rely upon hospice medical directors to assume that responsibility for the pain and symptom management and care of those patients enrolled in hospice programs. This new regulation is proposed by the Mississippi State Board of Medical Licensure would make it impossible for hospice medical directors in the state to assume care of these patients. Most patients are referred to hospice very late in the progression of their terminal illness. And the most recent statistics in 2015, 25% of all Mississippi Medicare beneficiaries who were enrolled in hospice programs died within 7 days. Over 50% of Mississippi patients who are on hospice expire within 30 days of enrollment. Over 50% of hospice patients have a non-cancerous diagnosis. And to require these terminally ill patients to meet with a new physician in literally their last days of life in order to maintain an acceptable comfort level is not only unacceptable but cruel. Many of the requirements within the proposed rule increase the burden for providers, patients, and families. Considering the debilitated state of the hospice patient, many of these changes would be impossible to meet. While hospice medical directors, they're well versed in pain and symptom management at end-of-life care, most serve only as part-time hospice employees because they all have busy practices within their local community. As hospice providers, we are not suggesting that we should be able to cut corners, compromise patient safety, or simply because our patients are terminal. Rather, we are seeking ways to break the barriers that would likely limit access to hospice care in general and increase the burden associated with managing these symptoms at the end of life. This new requirement is unworkable for hospice patients and would result in fewer hospice-appropriate patients having access to quality hospice care in our state. Hospice healthcare professionals, we applaud Mississippi State Board of Medical Licensure actions to bring an end to the opioid crisis, but we strongly recommend that hospice and end-of-life palliative care providers be granted an exemption from this new requirement. I have worked 30 years in the hospice and home care, and it's a passion to me, and patients at end of life, they are very, very special. And I just ask of you to please look at hospice and allow an exemption if at all possible. We request to have a more thorough dialogue. LMHPCO requests the board to have a more thorough dialogue with hospice providers who are very concerned with the unintended consequences that these proposed regulations will place on the ability to care for our patients. We want to be part of the solution, and we're willing to provide insight into this, but we just just please let us be able to continue to provide the high quality of care that we provide in our state. Thank you.
This is another area that we've discussed a lot. Clear something up. In chapter 2640, what we have done is a revision. We didn't create 2640. It's been around. I've been on board 12 years. The portion of 2640 which requires a health physician, that we license, to see a patient prior to prescribing scheduled medication is not needed. It's been in there as long as I've been on the board. So that's nothing new. I ponder this a lot, and I've had a lot of discussion about it, and I don't understand how anything we're doing is prohibiting a hospice patient from getting medication. I refer patients to hospice, and if I'm referring a patient, I write them a 20 or 30-day prescription of opioids until the medical director can come see them. They don't have to see them that day or the next day or a week because they've got medication. Then sometime within a reasonable period of time, the medical director or an APRN or whoever has prescriptive authority should go and examine that patient, in my opinion, and in the opinion of the way I interpret the federal government, should examine that patient and establish a doctor-patient relationship. It can also be done by telemedicine, by the way. And then opioids and benzos can be prescribed together. There's no prohibition on that because they're on cancerous patients. But they don't have to see them every time. They do have to see them one time. And that's been there forever.
But the problem is, you get a patient and they're, let's just say, like I said, 7 days, 25% die within 7 days. A lot of your primary physicians, they don't order. I mean, they may not want to order. I mean, they're the opioids and the benzodiazepines. So they rely on the medical director, the hospice medical director, which most in our state are board certified, to order the medications for the patients. Yes, they do. We are required to see a face-to-face, with the patient, but that's only after 180 days.
And would you, in the future, if you ever see a doctor who has diagnosed a terminal patient and says, I refuse to write you pain medication, please give us this.
They don't refuse, they just prefer for the hospice medical director to do it because that is well versed in that. Thank you.
Thank you.
The next speaker is from the Mississippi Nurses Association, and it's O. Stephen.
Hang on just 1 second, please.
Montanay. Is that right?
That's right.
You good?
I'm good.
O. Stephen Montanay from the Mississippi Nurses Association.
Thank you, Dr. Reynolds. My name is Steve Montanay, and I represent the Mississippi Nurses Association. I also want to echo the comments from a lot of the preceding folks who've talked to the board today, and forward to you my appreciation on behalf of the Mississippi Nurses Association for the efforts that you're undertaking to tackle this very difficult and important problem that we're seeing. My focus today is, I'm going to shift away from most of the substantive provisions that are in the new proposed changes and focus on Rule 1.14, which it is, the red line version is on page 45. Rule 1.14B, as proposed, provides that the pain management medical practice must have at all times a majority ownership more than 50% by a physician or group of physicians licensed by the board, and or a hospital or healthcare entity registered with the Secretary of State to do business in the state of Mississippi. The physician or physician owners must practice an annual average of at least 20 hours per week within the state of Mississippi. I understand from today's bullet points that the definitions that precede 1.14B have now been deleted because they were superfluous and they're included elsewhere in the regulation. This is a new rule. It potentially forces sales of clinic ownership interests. It ultimately consolidates business interests in the hands of physicians, where they could have been or are potentially in the hands of nurses or other business people. Supposedly the basis for all of the changes made in the document that we're talking about today is to, quote, reflect changes as proposed by the governor's opioid and heroin study task force. I reviewed that report, which is a fine document, but nowhere in it does it say, unless I missed it, that that there's a recommendation to the governor that we should be giving doctors more equity or more profit from the operation of pain clinics. There are many great doctors in this state, but this board has seen instances of doctors who are operating and owning pain clinics who are part of the problem. And so one question we have is why do these changes attempt to force a business result to consolidate ownership interests in these clinics away from other persons who also have prescriptive authority? It would allow, as written, the proposed amendment would allow any physicians, even those physicians who do not have prescriptive authority for controlled substances, to maintain a majority ownership interest in a pain clinic. There's no qualification in the word physician there. Even though in the definitional section that has been deleted as superfluous, we have a definition for prescriptive authority as meaning the legal authority of a professional licensed to practice in the state of Mississippi who prescribes controlled substances and is registered with the U.S. Drug Enforcement Administration. If the idea is to consolidate ownership in those people who have prescriptive authority, then why don't we change the definition or change the person who qualify as majority owners to limit those people who are in that category? And more importantly, from my client's perspective, why are we excluding nurses who have prescriptive authority from holding a majority ownership interest? In the same proposed amendment, other jurisdictions, such as Texas, have ownership requirements that include nurses with prescriptive authority as among those who have the right to majority ownership. It's not clear to me that the board has considered that. And as you go through this consideration process, we just ask you to think about the business impact on this and the potential to include other people who would have a greater interest and a greater obligation to follow these restrictions. I want to echo the statements by Dr. Meredith and also Dr. Grantham. Dr. Meredith suggested that this board should engage in joint promulgation. I think that has to happen. If we're really going to attack this head-on in a cohesive manner, then we need to involve all and regulate all of the practitioners who have prescriptive authority. So we need to involve the nurses in this process, and it needs to be a collaborative effort. Dr. Grantham said that we needed to have a coordinated effort, again, with all prescribing groups. This board has previously used its regulatory power in ways that could be characterized as minimizing the roles and business opportunities of nurses in the state. And these particular circumstances suggest either a similar course of conduct or simply a lack of consideration of those rights and the contributions of nurses in this state to medical practice. Again, changes in ownership requirements are not part of the task force recommendation. This is an extra change that appears to have been just thrown in, and I think it deserves more consideration. The Mississippi Nurses Association wants this board to know that this proposed regulation unfairly discriminates against their ownership and business interests, that they should not be excluded from any opportunity to be part of the solution from that perspective, The proposed regulation is, this aspect of the regulation is not a regulation that concerns the practice of medicine, but rather the ownership of business interests. And the impact of the proposed regulations to enhance the rights of physicians and the ownership interests and business interests of physicians, while eliminating and limiting the rights of nurses in that respect. The Mississippi Nurses Association believes that this is an improper attempt to regulate nurses, and it's outside the scope of the board's authority to do that. But we don't want to be an impediment. We really don't. We want this board to help solve the problem, and we want this solution to be done as quickly as possible, because we are losing people on a daily basis. We all know people, everybody in this room knows somebody, I would predict, that is addicted to opioids. Nurses are part of, can be and are part of that solution, and we want to be included. Perhaps the solution, and I offer my services to work with any of you, work with legal counsel, is in the proposed section 1.14B, simply change the phrase physician or group of physicians licensed by the board to person with prescriptive authority or group of such persons. That's all I have.
We didn't change that.
This portion that you're referring to was passed 6 years ago when I was on the board, and I'll give you a bit of explanation. This came about from some situations in Texas. Texas had the same thing, and we followed this. There was a pattern at that time of pill mills being owned by non-healthcare providers, be it hospitals, physicians, nurses, what. It was business people who went and opened up storefront operations, and they ran pill mills. So this is an effort, and again, this is 6 years old, is an effort to put the ownership and the operation of pain practices in the hands of those we license. We don't license nurses. This is a medical pain practice that we have jurisdiction over the licensees. It has nothing to do with nurses. And I mean, you would certainly know that. And to go back and say what you suggested, that this applied to anybody with prescriptive authority, we don't have the authority to tell nurses or dentists or, what they can and can't do. And that's not an effort to do that. I was just saying, if there's a pain management practice in Mississippi that's run, operated, or owned by a physician or one of our licensees, then they have to register with our board. If you're not one of our licensees, we have no jurisdiction on you. We can't tell you to do anything.
Well, thank you. To the extent that the regulations attempt to limit, minimize, or eliminate the business opportunities of nurses, we object. I read this amendment because of the red line included at the end as being a change in that regard. I think the language has changed, but I'll confirm that. Thank you.
Well, we can look at this, but this hearing was on the changes that we did in 2640, and that wasn't a change that I'm aware of.
Yeah, we changed it from 50 to 30%. The old rule is that if you have 50% of your patients leave your office with the prescriptions to X, Y, and Z, you're a pain management practice. Now, what we're proposing is 30%, which is consistent with our weight loss percentage. So that was the change in that. Nothing else changed
Dad,
that I'm aware of.
in all these things too, there are a lot of cross-outs, there's a lot of colors. A lot of things are merely rewordings or clarifications of other things. There aren't that many real changes in this one.
If I still have a little time, I'd like to get to the bottom of this if I can.
Sure.
On page 45 of the submission,
We have.
What section?
You have 27 pages.
I have 45.
1.14,
Page 23 is about.
page 45.
1.14 is about the 50% ownership. Which is on the
Yeah.
back page.
And so my copy says the physician owners, operators of the, and that part is crossed out. And that's a new change, correct?
That's proposed.
And so the impact of that change, and maybe it wasn't intended, but the impact of that change is that before, it was the owners and operators of the clinic.
That was changed because up above that, where it just came in, where medical practice is actually defined. And so it was stricken because it was redundant, because it had already been defined in the previous period. So it's already been defined, and so it was stricken just so as not to be redundant.
As I review the way I reviewed this is that if you had physician owners and operators of the pain management clinic, then they had to have a majority ownership of 50%. And now it's saying that all pain management medical practices must have majority ownership by physician or group of physicians.
Or a hospital or healthcare entity registered by the Secretary of State, which is hospital.
And so what I would simply ask the board to do is consider whether or not we should allow that to include those people who are defined as having prescriptive authority, not just physicians.
So you're asking for a new change, beyond what we changed?
I'm saying that this particular change in our group's perspective is exclusionary, and I would ask that you include all personal prescriptive authority.
Just for clarification, you're asking for a change that has not been made to this regulation. And we're here to discuss the changes we have made to this regulation. So you're asking for something that's off the table.
Well, no, I am objecting to this change. I'm objecting to this change because I don't believe that the old rule required a 50% ownership by physicians. I think that this rule was modified to clarify, perhaps, the intent of the board before, to have that requirement and to exclude nurses from that ownership ability.
Steve, it really did, the rewording that's been done is basically semantics. It did require, but the intention has always been to require that a pain management clinic that has been approved by this board had to be at least 50% owned by the licensed physician. So that part is not needed, but your comment is still well taken. What the board is, what he's asking the board guys, just like all the other comments, is just saying it objects, there's right or wrong, saying it objects to this, and would like to see it go a little further. But that's for the board's consideration.
Thank you.
The idea here was we had a clinic in Osaka that was owned by a retired policeman, New Orleans. And he was paying residents from the university to come down and sit there and write prescriptions all day. And we had no way to stop that, except to get to the residents. Well, they're not the problem, the owner's the problem. And after we got that lawsuit settled, we wrote this in the law, because we had to take that clinic.
That was several years ago.
That was several years ago, that was 6 or 7 years ago, and that's what this is about, is a retired policeman.
It's a great reason to do this, and I figured that was the impetus for it, is to have folks who don't have prescriptive authority.
But we're not trying to exclude it, except retired policemen from New York.
But Steve, it's important to understand that this document builds on itself. In chapter 2640, as all of our rules and regulations only apply to those people we license. It doesn't apply to someone we don't license. That's why the nursing board and the dental board has got to get on board. And by the way, to address what's come up several times, in the governor's task force, there was a commitment made from all these boards that they would mirror the governor's task force on opioid. And it's just going to be a matter of time till they do it or the legislature makes them do it, one of the two.
The problem, I guess, on this particular instance is if the Board of Nursing promulgated a mirror image regulation that says that 50% of the ownership of a pain clinic had to be by nurses, I would expect to have some problems. And so that's why I think that together, that there ought to be some more harmonious effort with all folks who have prescriptive authority. And so that's my point. I know you guys will have a lot to think about. I thank you for my time. I'll listen to my.
We see you.
Thank you.
Next, we have Dr. John Morrison, who also has no official capacity. Speaking for yourself.
Charlie, that's right. But you know me, I always do that. I'm not shy. I'm not going to mirror a lot of the other comments, but I do want to say I'm approaching this from a different standpoint. And that is, I do an awful lot of work for HMOs and other people who have been saddled with the administrative responsibility. And, you know, I just wonder if there's a template that other states have for all of these changes. Is there a computerized template? If anybody knows, Randy, you might know, you go to the other states, to keep up with these things in the record. Because if you try to do all these changes, particularly in the 1.7C, 1 through 5, and then 1.14, if you try to do all of these changes in your office, and everybody has a different way of doing them, number one, you're not going to get the same answers. The consults, laboratory studies, all of that, particularly in the chronic pain area. Not talking about pain management, but in the doctor's office. And so I wonder if the board could be of help to all practitioners out there to say, here's the way to get this done with the computer. And you don't have to handwrite it, you don't have to develop a computerized program yourself to be compliant. Because if you think HIPAA was bad and EMR was bad, a lot of these requirements are going to be just as bad for an individual doctor in the office to keep up with and make sure that he or she is compliant. The other issue that I guess I'm concerned about, one person did touch on it, is the 30% rule. If you look at psychiatrists, geriatric physicians, Martin Luther University, for example, or rheumatologists, there's no question that over 30% of their patients are either going to have opioids and or benzos, if not some of those other drugs in those five categories, in addition to opioids. When you do that, and you tell somebody to go back and do a residency, there are 100 hours. I mean, nobody's got time to go do 100 hours, and they don't want to do that. On the other hand, even if they don't do it, they've still got to refer the patient to a pain management clinic. I mean, if they're not going to manage it. And that means you got to get them in, I would say, at least within a few days, because you're not prescribing anymore for them. And I don't know about most pain management clinics, but usually it's 3 months, a month, 2, 3 months to get in. And what are they going to do in the meantime? I don't know that unintended consequence has been addressed by these changes. And so, you know, people that are out there are going to do what they've done in other states. And I just pulled 3 or 4 studies off the web, and I'm going to leave this with you. Mayo Clinic, JAMA, New England Journal of Medicine, and all of them are saying the same thing. There's physician burnout more and more because of dissatisfaction from the computerized stuff that we have to do to keep up with as physicians. We don't have time to even treat the patient, you know, much less make sure you're in compliance. Because some of these things, I have to say, are really pretty vague. If you got a patient you're going to be treating with opioids for several years chronically, and you got to do all of the things that they're talking about here, laboratory studies, objectives, plans, and you got to do that every so often, whether it's every 3 months or every year. Stop, think about how much time that is, even if you're doing it with computers. So what these are saying is that 1 out of 5 physicians are going to reduce below 20 hours per month, or they're going to quit. And most of them, 26.4%, say they just quit. And that's going to wipe out the next 3 classes of medical schools. I mean, if this many quit, then you have to have 3 years of medical classes to make up for that. They're not right. It's just a lot of unintended consequences. Now, I wish I could tell you how to address this and get what we want to happen done, but I don't think we're trying to penalize people who are doing it right under their own, let's say OBGYN or internist, internal medicine societies or geriatric societies. If they're handling it right and they're treating their patient according to their society's evidence-based structure, then it's going to be awfully hard for us to write a rule to do what we want to do and at the same time have no bad unintended consequences. Wish I had an answer for you, but I know it's going to be a problem. So let's don't throw, as an obstetric expression does, let's not throw the baby out with the bathwater. You know, let's make sure that when we enact these rules and sign off on them, none of these bad things will happen like Dr. Currier said. I mean, if we got 68,000 people that are addicted, who's going to take care of them? You can't just stop it, or if you do, they'll just go to higher drugs. So anyway, let's take a step back and think about this, and I'd be willing to work on it with you any way I can, and I'll leave this for you. Thank you very much.
We appreciate you bringing up another problem that we don't have as well. Put
Well,
that on
Charlie,
the list.
listen, I'm right behind you, and depending on how bad the problem is and how serious it is, it'll depend on how far I am behind you. So I'm behind you.
As soon as our website comes online, we'll write it.
That's right. We know who to do it now, don't we, Dr. Ray?
Sure. Dr. Grantham has a clarification right quick, I think.
What you said about the 7-day thing, tell me what the MSMA recommends on that. Because I sure thought you said 7 days limit.
No, what I said, Dr. Easterling, was that there is a limit for acute pain, 7 days initially. But if there's appropriate documentation in the record, that could be allowed. And I believe that's what the letter states, and actually gives a little more detail in the guidelines.
Okay, 7 days initially for acute pain and there's proper documentation. What?
That there could be additional prescription if the illness lasts, or the pain lasts longer, is perceived to last longer than 7 days, or you, in your medical judgment, feel that for these reasons it should be there, that there would be exceptions in those cases, as long as the documentation in the chart is appropriate.
That's
Your medical logic.
exactly what our rules and regs say.
Yeah.
You can give, we recommend 3 days, you can give up to 7, and you can refill that 7, so you can get 14 days.
Right, but remember I asked that we pull the regs as they are, and that was my substitution, so that's why I listed it again as a first. Well,
Yeah,
anyway, that was just clarification.
Okay.
You know, a lot of problems can be solved here with adequate documentation of what you're trying to do and how you're trying to do it. And nobody's gonna mess with you if you're doing the right thing. Anyway.
Absolutely agree with that.
Absolutely. Thank you.
I hate to do this, but can we have a break?
Yeah.
We'll be back
Get the blood flow.
5 minutes. Dr. White.